You know, we have heard about some amazing things today. I mean, it is tremendous to hear these really, really cool things going on in healthcare today, right? But with all of that comes an increase in risk and an increase, right, in complexity of healthcare today. At the Joint Commission, we actually have something called the Sentinel Event Database, and it's where healthcare organizations actually report when preventable harm happens to patients, like death or permanent harm. So it's a huge database. And we actually analyzed 3.5 years of data, recent data, and it turns out there were 120 incidents that were health IT related, Sentinel events. So, you know, EHRs have the potential to do amazing things, right? Mm-hmm. But there's all these obstacles. I mean, first of all, we're harming people, right? The top 3 were medication errors, wrong site surgeries, and a delay in treatment related to health IT. So safety's an issue here, right? Not to mention the massive data, how do we make knowledge or real information from all of that? The cost, interoperability. You guys got to help me out here. So Dick, you know, as the founder of the Rothman Institute, a practicing orthopedic surgeon, you focus on hips, right, knees. So, you know, what can EHRs do? Do they really support quality, good, great healthcare that all of us want for ourselves, for our families, and our friends? Do they do that? Can you give us some real life examples from, you know, as a business person, as a clinician?
Well, there's some obvious things, and there's some things that we tend to ignore that are probably more important. So the obvious things, Aaron, you threw me a nice, easy ball to at least get a double out of this. Everybody knows about drug interactions. Those flags should come up because there are a lot of odd drugs that people take that we're not aware of. That should be flagged in 1 minute. 2, we now know risk factors that are cumulative. I do hip replacements, knee replacements. If you've got HIV, diabetes, and renal disease, the odds are we'll make you worse if we do a hip replacement or a knee replacement if you've got a worn out joint. So there's statistical predictive modeling that lets me make a better decision, lets the patient have a better outcome, and saves a lot of suffering and money. But, so there are 2 home runs, but the risk-benefit ratio with the electronic manipulation of this data is, I've got 10 minutes to talk to a patient and make the biggest decision in their life. Should they get a hip or a knee replaced? Maybe getting your heart replaced, a little more important. I think the knee and hip, Bobby, are more important.
The heart just pumps blood to the knee.
They've got 10 minutes, and they've got to look you in the eye. And if I'm turned around typing on my computer, they have confronted the back of the head syndrome, which is the risk. And you lose that marvelous interaction of compassion and caring. So that's a huge risk that we somehow have to talk about. And then the last one, then I'll stop, is the risk of loss of privacy. We were saying that one of the world experts said 97% of corporations are hacked today, plus the NSA is hacked. We all know that. Just think, we worry about financial data, medical data. Think about if you're a leader, which you all are, and you have depressive thoughts about harming yourself or harming somebody else, and you share that with your psychotherapist, and somebody hacks into that data, that risk. And we've got to confront how you handle that as a provider. I think there are different levels of consideration that often aren't thought about.
Sure, thanks. Could we have the slide, please, for the consumer survey results? So yes or no, electronic health records improve patient care. So 63% agree somewhat, right, with that. You know, what do you think, Bobby? I mean, as the president and CEO,
Isn't there another one where what we say?
well, that's what I was going to ask you. You know, do they really
Oh,
improve
yeah, see,
patient
this is
care?
us. This is all of us.
All right.
Yeah, all of us in this room think
Here
so.
we go. Here we go.
Yeah, so I'll...
And we're the scientists.
Yes, well, you
All
stealing
right.
my
There's the data.
thunder
All
here.
right. I mean, how do you balance?
Where's George? He's back in the green room still talking about, you know, how we're all idiots because the scientists know and we don't. And Dick, I'm very disappointed you agree with George. You sitting in this chair that if you operate on and replace someone's hip, you're going to make them worse, you know. It's not like all those people didn't try all those things before they got their hip replaced. Yeah, I think that, you know, obviously we're not going to go backwards and start using payphones and run around. You got a quarter, Jonathan, that I can pop in the payphone. We're going to, you know, we're going to use electronic health records. I would agree with everything that Dick said, and you know, just for transparency, we had a phone call before this, and we talked about some of the things we were going to say. The thing I would say is we're not going back to payphones. We're not going to go back to rotary dial phones. We're going to move forward. So I think it's an opportunity, and some of the real scientists here can tell us in just a moment what some of the opportunities are to make the systems better. I agree with Dick. You know, the last thing you want to do is be over typing, you know, on a keyboard when you really should be talking to the patient and finding out what their hopes and dreams are and what they're all about. So I think there's opportunity, voice recognition software, things that can take away some of the issues that Dick was mentioning about what I would call the customer service side of things. These guys know much more about security and can comment on that. You know, as we were talking before, you know, there's no 100% safe system. So you know, there are going to be things that with, you know, 99 degrees of encryption that you can get it more safe, but it's just like we were discussing backstage that, you know, we can have 0% mortality with cardiac surgery if we don't operate on anybody. So there's risk in everything we do, and it's, you know, how much risk would one want to take? I would agree with most of the people in this room. I believe that the electronic form of record keeping definitely improves quality. You cited a couple of things. There was a New England Journal article a couple of years ago about miscalculations and some of the unintended consequence of electronic medical records. But on balance, I think it's definitely an improvement. It's a place you can get all the x-rays. You don't have to run around finding the chart and trying to decipher somebody's bad handwriting. And so I think on balance it's a good thing, and but there's definitely opportunity for improvement.
All right. How do you balance really the, you know, the safety checks that you would have in a system with your staff and the alert or the alarm fatigue? I mean, how do you prevent staff from going crazy, right? You don't, like you said, if you don't operate, you won't kill people, essentially, but we have to take care of people. How do you create that resilient system? Where do you find that balance as a healthcare leader?
Well, I think it becomes part of the culture. I mean, there are, you know, just if you want to get down to the simplest form of, you know, safety, is hand washing. Well, if you want to look, we don't do a very good job of hand washing. There are certain institutions that do a great job because they've done it so much to ingrain it in the culture that it becomes part of the everyday practice. And of course, that's the hope that we would do with all these checklists, that would be not just pro forma, but it would be truly part of the culture. It's an important part.
Right, but how do you, you know, really get there? A checklist alone, right? Is that enough? It's a, you know, it's a place, but you need leadership commitment. You need a culture, as you said, that drives that, and you need robust process improvement. I mean, you need an engine that will drive that, right?
Well, I think you said it. You know, it comes from the top. It comes from the leadership. But that you, as you were pointing out, as we were chatting earlier, you have to create a culture that says that one of our main goals is to do no harm. I mean, we all raise our hands and say we're going to do no harm, right? So that's you know, to have that part of the culture to say we're going to provide the highest quality care would be part of that, which is safety.
Right. And
Part of it-
perhaps washing one's hands is one of the places to start.
It's a
for
good place to
reliable
start.
healthcare,
It's a
right?
good place
Yeah,
to start.
Part of the problem, Aaron, and probably Paul may leap across the stage and strangle me with these comments, is we're driving a Model T Ford as we give up the horse. And I really would rather drive a Maserati than a Model T Ford. But how do we do it? We're not going back to horses, I don't think. And you have the clinicians on one hand who are frustrated by the shortcomings, and the experts in information technology who really know that this is going to lead us to a better spot. And either we have to educate people better in both spheres or work together more effectively with clinicians and the IT guys. And I think that's the answer.
So Paul,
Yeah.
as the president and CEO of Allscripts, what is something that you hear commonly from your clients, from the CEOs there, that is, perhaps not necessarily true in your opinion, and that they need to be educated on or need to understand better from your perspective? What are some myths that you debunk when working with your clients?
Well, I would say that the comments around safety, everybody in this room is very dedicated to that, and I've never met anybody inside of healthcare who doesn't think about that every single day. A lot of the premises that a lot of these foundational systems, and I mean systems with paper systems as originally originated, or as Jaco and some other folks, when they come into your organization, they'll talk about what are the processes you have in place today. And for guys like us, Jonathan and I, that try to automate those processes, we try to make them more efficient. And that's what we have been embarking upon as we've gone down this road of electronic medical records. At times, we actually have made the workflow complex. Sometimes we have to make the workflow complex because there's certain data elements that we're required, or they are required from a quality or reporting standpoint, that must be gathered. And you've missed an opportunity as a byproduct of doing this automation if you haven't captured that. So there's a data model, there's all sorts of complexity. But at the end of the day, if we've got senior folks that are doing really wonderful work, literally saving lives and improving people's quality of life, who are saying this impedes me, we have to listen to that. Does that mean there's too many clicks? Is there a different way of doing this? Is there, as was mentioned, some other way to do the data input so that I can have a eye-to-eye conversation like the way I grew up? It is important, but there's also, there's no substitute, in my opinion, for the value that's garnered in the back end, if you will, of all this data that you have as a result of this deep process clinical and financial automation.
But getting the data
You're not
out
buying
is
this.
so hard.
It is hard.
to get the data out
It is
in
hard.
a meaningful way.
It's also very hard to go in and abstract charts, as we all know.
Fair
Any
enough.
of us who've gone in and tried to abstract charts.
Okay.
Yeah, so as some of you know, I'm on the chair of the board of a public hospital in Kansas City. One day we go in the clinical quality deal and we find out, so what's going on? Well, we need to hire 7 people. We said, well, at the time, we're a completely paperless institution.
Yeah.
What are we going to hire 7 people for? Well, we just got 224 new CMS requirements for quality reporting that we have to go hire folks to be able to do the data writing. So it is, the immensity of the requests that are coming into these organizations for all sorts of things, especially now that the government knows that they've paid the money for the stimulus program, and they know that these folks are automated. They know that the data are there. They're asking for all sorts of stuff today at an accelerated rate that they weren't even thinking about 3 or 4 years ago.
But are you starting, I guess, in the EHR companies asking, what is the data we need to improve care, to get the best care, and starting to build the systems from there, from the patient's perspective of what is the best care, and then working backwards, because that would make that measurement much easier, perhaps, in that sense.
It would, and MU2 is a great example of that. There's a bunch of folks that Jonathan and I get calls from every day and say, are you out of your mind? Have you thought about this workflow? It really works this way? And he said, we're trying, we're doing everything we can, but that data has to be collected for us all to be compliant with the MU2, and now further on with the MU3. We're not hiding behind it, but there is certain things that we have to do in order to be ONC certified, for them to get paid, et cetera. Not that they're just doing it to get paid, but it's an extraordinarily important piece of the pie. We'll go back through, we'll optimize, we'll do all sorts of other things to try to improve the patient flow, but it's a fair amount of work, and we're trying to simplify it every day.
Great.
But
So
just
Jonathan, hold on
can I
one sec. Jonathan.
Yeah, go ahead.
Jonathan, So as the co-founder and CEO of AthenaHealth, right, you know that, we all know that EMRs are really very, very expensive right now. The implementation, the optimization, all of it is right now. And in fact, the description in the book says extortionate, exorbitant, actually, right? So, I mean, is a high-quality, reasonable healthcare EHR possible? Is it achievable someday? What are the speed bumps between here and there?
Well, so we're sitting in a 400-year-old city hosted by a magazine in 2014 talking about enterprise software. Like, and is it a good idea that we switch from paper to enterprise? Everything in all of our lives is on the internet. And we're deciding the puts and takes on buying frickin' Model Ts, payphones, like a better pay. Are you kidding me? And how will we get the data out? And how will we get all the different government, widgets to be lined up? The airbags have to be in place, and the, it sort of feels like that, and then the airbags don't work. The meaningful use screws up the doctor's workflow, but you have to have it in order to sell your car. My head hurts. Like, this internet thing, I swear to you, is going to be big. Of course nobody should spend years installing things. Of course nobody should spend millions of dollars to generate a miracle. Negative labor productivity to technology investment. You can actually increase your administrative staff by buying labor-saving technology only in healthcare. It's a weird retro world. It's like Blade Runner, where in Blade Runner, in the future, there are still, the cars fly, but there are still public phones.
Yes.
Right? So he goes up to do a video public phone. Remember Harrison Ford in the Blade Runner? I'm having a weird nether world, like fake future moment here. Like, survey about whether, it's absurd that all these hospitals are buying these islands, and medical groups, no offense, are buying islands of automation and then having their own little EMR departments, creating their own little patchwork quilts of their own little data set. And then, Texas Medical Center does a beautiful, Texas Health Resource does a beautiful job responding to a screw up, but they're this tiny little island of automation. Of course they weren't surveilling for Ebola in Dallas just right. When you go to do it, how many emergency rooms in the country have people who have diarrhea, muscle aches, and a fever right now?
So how are we going to get there?
We got to go to the internet. We got to skip
We've got to go to the internet.
software. We must connect care. Care must be connected. He's doing it. Well, Allscripts is doing it.
What's standing between us and getting there?
The EHR business model, the word EHR, the notion of a noun as a piece of technology.
So
health information networks, right?
Okay.
We all need to assume ourselves to be health information networks. And there's 1,000 things that are in the way. There's an anti-kickback law that makes it illegal to have an interchange payment between a doctor and a hospital. That's retarded, Of course, if a doctor provides all of the information to register a patient electronically, prevents the person in the hospital from fat-fingering it incorrectly, the doctor should get $5. You go to jail if they do that.
Bobby?
That's one example.
Bobby, any thoughts?
I'm just glad he's here to provide, the excitement.
Sorry, I'll it's too much coffee. I'm done.
No, that's just right. Go ahead, Dick.
I think the cost is a real issue, and again, Paul is going to have to be chained into his chair if I keep this torment up. But when you really look at the cost, it is an impediment because it's a zero-sum game. If we spend 30% more here, 30% of people are going to get shortchanged somewhere else. So this is the real world of cost and convenience are our two big drivers today, and it's the capital cost, the cost of maintenance, the cost of hiring people to input data, and the, let's for argument's sake say a 30% slowdown in throughput. You add that up, that is a substantial cost for electronic medical records. And
So let's not do that.
So we've just got to get smarter. We've got tons of data. We've got to get better algorithms, more efficient systems, and more people working together to solve the problem. We can't just say, these are bad guys, we should get more money, or you should, or Jonathan certainly deserves more income for his company. We've got to be a little more cooperative.
I'm going to do one more question, and then I'm going to go to the audience if somebody wants to start getting lined up. Paul,
Yeah.
so how would you design, I mean, what is your dream system network thing?
But I think if, you know, what's fun about where we are today, and it doesn't feel like fun, but people that have been in this industry for a long time know we've spent the last 30 years automating everything. And for those of us who think that we're done, you've really missed the point. You now have all of healthcare digitized, which is pretty cool, okay? It's incumbent upon us to really now do something with that. Unfortunately, there's different approaches in the marketplace to how you would make this all be actually valuable to people. And when you interview caregivers, what they're interested in is give me the entire community view of everything about Erin that's out there in the entire marketplace. That she's basically been pinging this marketplace in New York City, you know, the Walgreens here, the Mount Sinai, Presby, wherever she might have gone, but I want to see it all. I will finally get value as a caregiver if I'm able to see everything as I'm seeing you in my clinic or in my ED. The place where we have been able to do that, where we ask the question of does this actually provide value, when they can see the total community view of everything, including the scripts, the easy scripts, the stuff that's been out there, that's been at least prescribed, they picked it up, we don't know if they took it yet, maybe our AthenaHealth folks were going to be able to help fix that, but I now have an exchange where I actually get something back as a caregiver as I'm sitting there typing at it, and I actually get a community view. But what we have, the data that we show is that 67% of the time, caregivers at one of our largest institutions see the community information versus the campus information, the stuff that's just inside of my IDN. I will make a different clinical decision, 67% of the time. That, to me, shows that there's promise for and there's actually value in these systems today. If you want to spend a boatload of money and rip them all out and put another one in, go for it. I'm saying these organizations, they don't have the money. They've got unfunded mandates. They've got charity care. They've got depreciation. They got everything they're trying to go spend money on. And to go rip something out that's working and go put something else in versus putting a layer above, whether you call it the internet or whatever we're going to call it, people think that, as Johnny said, I think they've lost their mind. A board has got to wake up and challenge these folks as to what in the world are you thinking?
You heard it here, folks. Allscripts is going to the cloud.
So, yes, please. Thank you. Can you give us your name and where you're from?
I'm Steve Klasko. I'm the CEO of Jefferson Health System. So when I go to my hotel, I can get on the internet for $15, and then the competition is what I do after that. Right. Where things have failed is if you're an investor in Allscripts or investor in Athena, in the case of Allscripts or Athena, or the state of Wisconsin, in the case of Epic, you've done very well because it costs $300 million or $200 million or $100 million to get on the internet. So the fact is that by definition, it's become almost an anti-innovation piece because if I'm Allscripts, that's great. I now have, I'm not going back to phones, but that's all I can do is Allscripts. I can't interact with other folks. I can buy something else to interact with other folks. So the model, in my opinion, needs to be one where everyone can get on a platform like the internet, and then the apps are what you buy, and then you guys compete for the apps.
Yes, but that's, I mean, nobody's going to spend any money, no one's ever spent any money getting on AthenaNet. All of Ascension, $5,000 went live, it cost them $800,000 and they were done in 9 months. It's right, it's true, it's happening, and yet we're still having panels talking about, you know, how should we shape our $100 million 5-year implementation? It's absurd, right? Of course what you should, everywhere else the software is not the thing. Everywhere else the software is the store you go into to get the thing. Nobody bought a copy of Amazon here. We walk into Amazon, digitally walk in, to get stuff, and Amazon makes money when the stuff happens. Athena makes money when the claim gets paid, when the order matches the result, which even when doctors have EHR, half the time, it doesn't match the result. It disappears, right? That's crazy. Of course people opt out of care. If 35% of the time you have an abnormal pap smear result, you're never going to find out. Why go through the discomfort and cost, right? So of course, but the point is, everyone can do this. You don't need to keep paying money for copies of software that in and of themselves are not connected to anything. I can't believe we're still talking about it. It blows, well, it's actually right now blowing my mind. Like here we are doing it, it's, you know.
Yeah, and we also, though, we expose APIs. We have over 100 different application developers that are out there writing applications on top of our software. I gave out $1 million at our annual users group 2 years ago to 4 different firms. We had an open app challenge. So we are incenting that. We're creating that platform for people to go do that. You do, though, have to have the platform. The apps have to plug into something. And to me, this something has to exist out there. Right. I've always been stunned by the internet bubble. I was like, I really wasn't that stunned. There really wasn't an alter economy out there. The reason why the internet bubble blew up is it didn't attach to anything. Stuff was just out there. Today, if you can make something like that attach to something, and you can actually I can talk to Dr. Klasko, my OBGYN, then there's value there. But if I'm just on an app looking for OBGYN information, that's really cool, but I can't talk to you. And that's what eventually she's going to want to do. I've got this problem and I want to talk to you. So there's a bunch of wiring, unfortunately. There's a bunch of hard work. There's a bunch of boiler room stuff that has to occur in order for this stuff to get connected. Once it's connected, though, APIs and have at it. And that's what we've been doing for a long time. It's now cool to say you're open. We've been open for a really long time. We teach classes every week on it.
Dick?
Yeah, I just want to get back, Aaron, to if you were my genie and can deliver whatever we wanted, which I expect, of course. I view myself as a retail person in the healthcare business. Mm-hmm. So my perspective's a little different. I would want a couple of things. Voice recognition, so I don't have to be a typist. I'd want absolute security, so I know my patient's thoughts would be confidential, and I'd want it much more affordable than our current model, which is our joint responsibility.
My name's John Quackenbush, and I founded a company called Genospace that produces precision medicine reports using genomic data. And I think Jonathan pointed to the white elephant standing out in the middle of the room that nobody ever talks about, right? We can sequence a genome for $1,000 and get data back and interpret it in very rapid times. And when we were building reporting software for one of the clients we work with, we went out and met with community oncologists, and 85% of cancer patients in the US are treated by community oncologists. And the design criteria for the report were 2. It had to be really simple and easy to interpret so that in 2 minutes they could make the best recommendation to their patients because they only have 10 minutes in dealing with patients that Richard suggested. But the other thing that just blew my mind was they wanted a single-page PDF. And you ask them why. And the answer is they want to print it out so they can manually scan it into their EMRs. Right?
Yeah.
So
the EMR department, right?
That's right.
The fax server. You know.
Exactly. It had to be faxable 10 times and still readable, right? So we're building this castle on this steampunk implementation of an electronic medical record that sits underneath that even though it's electronic, you can't get the data out because it's a device designed to turn a room full of files into a disk full of JPEGs.
How do you
Agreed.
experience
Well
it,
said.
Bobby?
I think that's racking. He just got the whole thing right. I think all these points are very good ones. I wanted to go back to about all the data and how you retrieve it and manage it. You know, if you're running a hospital, you're trying to study to the test, as we talked about on our call, and that means that the data is not always the same data. UHC requires you to have different data than Joint Commission, who requires U.S. News and World Report is grading you on a different thing, and American College of Cardiologists or STS data is different. So I do think that there has to be this holistic approach, and you know, I'm learning more about electronic health exchanges. In Houston, there's one called Health Connect, and I think we got to get to a point, and if Patrick's, you know, card works, where we're all taking our data around, which is what the consumer always wanted, right? Is that you would be able to see all the interactions and all the data in a hopefully easily searchable way.
Didn't we get over the card with Newt Gingrich? The chip? This internet thing, I swear, you look yourself up and it's all in there.
It is.
And the internet is in a lot of places. So the idea that you then carry a chip, that somebody has to have the chip receptacle, Blade Runner, like video public phone. Are you kidding? Sorry.
Well, so wait, but you have to have it segregated somewhere, and thank God for Al Gore. If Al Gore had not invented the internet, you could
I owe my
standing
fortune to
up.
Al.
You
Right.
do, you do.
That's right. I would say the proliferation of data is crazy. So we're all wearing wearables. We got all this stuff. To me, it's got to though be put in a way that a caregiver, it's going to make sense to them in their specialty with that person. So the workflow. People talk about analytics, people talk about all sorts of other great, wonderful things because of the proliferation of all this data. If you don't bring that information back in a consumable way to the caregiver, we've all wasted each other's time. So you can plug into the HIE, I call it shouting. So I click on my tab on my HIE if I'm in my EMR, and boom, I get every single transaction that's ever happened to that patient in the entire state of Kansas. It's ridiculous, it's a PDF, okay? It's ridiculous. And so I say, don't shout at me. If I'm a caregiver, I want a delta view. Since the last time I looked at this patient, I want to know what's new, what's different. Just like the internet. Go check your stock, it goes up or down. What happened since the last time I looked? So to me, you need to have a delta view. That makes it valuable to the caregiver. Don't give me everything. I just want to see stuff for me, for my specialty, since the last time I looked at it, and put it in some context. And give it me everything that happened to this person across the community, not just what happened here. That is how I think we'll actually provide some value to this big, huge, cool set of information that's now flowing our way. I call it whispers. If you whisper to somebody, they're going to pay attention to you. Got a little bit of community data up here. Do you want to see it? Yes or no? The last 10 times you clicked on it, it worked. I dug it, and I did something different 70% of the time. They're going to trust that, and they're going to go to that every time. That will be, I think, one of the first times people are actually provided to the caregiver, not to the system, not to the administrator, the caregiver, some value back. I can see what my colleagues are doing with this person that's in front of me now.
We have a question here?
Yeah, I'd like to make a point
Thank
as
you.
a provider who actually happens to be an AthenaHealth user, and I would say, Mr. Bush, some of your views are very simplistic. I mean, it's more than the internet. It happens to be a very costly endeavor. But I would say that I think providers and patients have different views of how they view EMR. And obviously we accept that EMR is the wave of the future. But I think today in 2014, EMR, EHR is 20% healthcare delivery and 80% a charge collection document. And unless we
Or a JCO protection document or a legal,
unless we untether that basic thing, we cannot restore the doctor-patient relationship. As long as I'm getting paid more to check off boxes that have nothing to do with why you came to see me in the first place, we will never maximize the real appeal of EMR in clinical practice.
Yeah, can I respond to the It's true that what I said is simplistic about the because the problem isn't the software. We should all be walking into a store to get at the problem, which, as you point out, as an Athena client, God love you, is expensive. So dealing with insurance companies is expensive. Dealing with meaningful use and getting the money is expensive and complicated and gets in the way of the moment of care. So what we spend time on as a company is not getting you turned on and set up. It's actually surveilling your patient population and looking for people who have gaps in care and filing your claims and finding the orders that never matched to a result. We've got 3,000 people actually moving health information to connecting your environment for you, and that's expensive, and it's much more complicated. And to your earlier point, the security requirements on us, right? We have malpractice coverage as an IT company. We're a covered entity under HIPAA as an IT company. No other IT companies are, because we're actually in this muck. What I was commenting on is the idea that we're talking about this noun form of enterprise software as the conversation, as opposed to this much larger and more expensive question of information management in a sort of massive signal-to-noise mess-up that is healthcare chart information. It can't be abstracted, can't be summarized. We should be talking about what you're talking about, not enterprise software.
Right. Question. Can you introduce yourself? Thank you.
My name is Robert Gottfried. I'm the president of and CEO of a software integration company. And I'd like to point out that basically I'm a plumber. And the problem is integrating these systems. It's not a question of exposing 4 APIs. When we go to Kaiser Permanente, they have 4,000 separate systems, including clinical systems that some doctor invented in 1988. Yeah. And the elephant in the room, who's in Madison, Wisconsin, has a system that was basically written in 1970.
Flock of seagulls were at the top of the charts.
Fair enough. I find it very difficult to find people who are old enough to know how to operate that system. So from my perspective, aside from the difficulty of finding competent software developers and integrators, there's so many systems out there. Some of them will never have APIs that are exposed. Sometimes a doctor wrote it in 1987 using HTML1, and that really is the essence of the issue. Trying to integrate these systems is a real nightmare. And as a plumber, I can tell you I'm covered with those things that plumbers are covered with, because it's really difficult to bring everything together. It's a major problem. The country doesn't have enough engineers to produce enough people to do it. And until you address those problems, you're going to find EMRs and EHRs are very pricey and very difficult to use in a practical sense.
Yes. Our job should be to connect care, not to provide software. It should be to make those connections work. Well, I think we do the same thing, which is if you're stuck in the pre-cloud world, we have plumbers that will come out and, think, bust open your database to get information flowing. We have 160,000 today running right now connections off of the cloud and into pre-internet systems that our clients have, the lab spinner, the whatever hospital system or mumps system they may be on or whatever. But then we've got a small group, and I think you do too, in a marketplace where the other company has built a really solid trunk-to-trunk API. So now there's no customer does any interfacing. They look up the name in AthenaNet, they turn on the setting, and boom, they're in there. And we just have to look at one connection between mothership to mothership, and we keep that one trunk running, and then nobody has to wonder whether the interface is down or what happened to the message and what are the field mapping, the best way to map the fields.
I mean, really, at this point, where's the patient in all of this? I mean, let's circle back to all of us, our friends, our families, when we come in contact with the healthcare system. What can every single person in this audience do to protect patients from the harm that is caused from health-related IT things today? Can we end the panel with that right now, a recommendation from each of the panelists?
On the EMR side?
Yeah, what can we do? First, do no harm.
Well, I think to do no harm, we have to finish. So that means we have to finish deploying these systems. That has the promise of not operating in multiple different environments, some paper, some not, some phone, but it needs to get digital in order to have any promise at all of being able, in my opinion, to really assist the people that are already sworn to the oath of causing no harm. Nobody tries to do that every morning. None of the caregivers we work with, they're all actually discharged in many cases with dispatching miracles from my perspective. And I think that until you get everything automated, you'll be living in two worlds, two systems, and anytime you live in two worlds or two systems, the chance of error goes up dramatically.
Yeah, exactly. Dick?
Yeah, I think, I'll put it in words that a patient wouldn't want, but I think the patient really wants, aside from compassion, is better decisions about what they should do. And that means improving the signal-to-noise ratio so they can make a good evidence-based decision, weigh the risks, and decide, do I get the operation, do I take the pill, or do I just accept what I have?
And Bobby, any thoughts about how to protect the patients? What can every person do in this
Well,
audience
I think
with that
also
agenda?
as we were leading off talking about culture, a culture of, and we're seeing this more and more, patients being more involved in their care. So having patient portals where they can go in and look at their data and be part of the decision-making process instead of saying, to Dick, well, Doc, whatever you tell me to do, I'll do. So I think there's some advantage to that, to be able to have them educated to be able to look at their data and have a meaningful and intellectual conversation, and to have some accountability over their own care so that they can look at their data and hopefully it'll change their behavior in some ways.
Jonathan?
Okay, so we have to connect care. To protect patients, we must connect care. The amount of fat fingering and lost handoffs that we do is a murder mill, right? The second thing, once care is connected, we need to suck the shit work away from the moment of care. So we have all this data entering and JCO complying and coding complying and medical legal protecting going on in this moment of care. And once everything's connected, that work can be moved away, done fewer times more accurately by focused factories, right? Then suddenly you've got just the care left. You've got a tweetable, readable, decidable piece of information that doctors, as Rothman said, doctors, a consumer, needs to be treated that way too, and then ultimately patients. But I think that's the order of attack.
Great. Thank you all.
Thank you
Thank
very
you.
much. Thank you.